Happy Friday, everyone. My name is Ashley Johnson. Welcome to NAHUD's Bridging HIV and SUD Innovation in the Field webinar series. Today's session is Approaches to Substance Use Disorder Treatment for Non-Abstinent Patients. We invite you to use the chat to engage with your fellow attendees. To start, please add your name of your organization, and for our icebreaker question of the day, what are you hoping to gain from today's session? Throughout the session, please use the Q&A pod to ask your questions. The speaker will address them at the end of the presentation. Today's session will be recorded, and a PDF of the presentation slides will be added to NAHU's website as a resource. You will receive this information in the post-webinar email that will be sent out through Zoom. You can also visit NAHU's resource page on the website to find this resource and view past sessions. NAHUD is a membership organization of 8 regional and 2 national AIDS education and training centers, AETCs, that support the AETC program mission. Established in 2010, NAHUD supports the AETCs, a component of the HRSA Ryan White HIV/AIDS program, which have an explicit directive to build and maintain a well-educated and culturally sensitive health professions workforce that can provide prevention, diagnosis, care and treatment, and medical management for people at risk for and living with HIV. NAHU collaborates with multiple organizations in order to promote and educate on the work of the AETC program. Since 2018, NAHU has been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network, ORN, to address the intersection of HIV and opioid use disorder. ORN was created to support efforts in addressing the prevention, treatment, recovery of opioid use disorders and other substance use disorders through the provision of locally designed education and training. Visit the website to submit a TA request, read case studies, and see feature resources. Check out upcoming ORN events and trainings, and learn about ORN work groups addressing health disparities and more. There will be a post-evaluation survey that will be emailed to you after today's webinar and must be completed within 2 weeks to receive CME, CNE, Social Work CE, or a certificate of attendance. After 2 weeks, once the survey is closed, it will not be reopened. The minimum attendance requirement to receive CE is 60% of today's webinar. Participants who accrue less than 60% will not be eligible for CE. If you are a phone participant, please contact Liz Lazo to verify your phone number and to receive the evaluation link. Certificates will be emailed within 3 weeks of completing the evaluation. CE credits issued for participation may not apply towards license renewal in all states. Each participant is responsible for verifying the requirements of their state licensing boards. Today, we have the pleasure of having Dr. Sarah Axelrath. Dr. Sarah Axelrath is a board-certified internist and addiction medicine physician. She completed her postgraduate residency and fellowship training at Massachusetts Hospital and Boston Healthcare for the Homeless prior to beginning her clinical practice at Colorado Coalition for the Homeless in 2021. She has over 10 years of experience working in this field and with people experiencing homelessness. She now provides full spectrum integrated primary and substance use disorder care to adults experiencing homelessness in Denver, Colorado. Without further ado, I'd like to turn it over to Dr. Sarah Axelrath.
Thank you, Ashley, and thank you everybody for having me. I'm excited to be here. Give me one moment to share my slides and then we'll get started. Okay. Ashley, can you see my slides okay?
Yes.
Excellent. Okay. So thank you so much for having me, everybody. My name is Sarah Axelrath, and I'm an internal medicine and addiction medicine doctor at Colorado Coalition for the Homeless in Denver, Colorado. Today, I'll be speaking about approaches to substance use disorder treatment for non-abstinent patients, which I think is a crucial skill set for any clinician working in the field of addiction treatment. I'll be drawing on a number of sources that give this talk, not least of which is actually a best practices guide published by SAMHSA in the fall of 2024, as well as some other primary literature in the field. And of course, some of it will just be my opinion, but I'll try to disclose when that's the case versus using more evidence-based sources. So here's what I hope you'll take away from the talk today. To summarize, I hope what you'll take away from this talk is an understanding that people in treatment for substance use disorder do not necessarily need to be abstinent from all substances in order to be considered sober or to be successful in meeting their goals. And as a quick roadmap for the presentation, first I'm going to talk about why it's important to engage non-abstinent patients in treatment before transitioning to talk about how we do that practically and hopefully give you some practical tips and tricks that you can use on your own. So we all bring unspoken assumptions to our work, and I tend to think that we're just more honest in our work when we acknowledge them. So I wanted to give you sort of an approach and a framework that I use in this work. These are my starting assumptions. They definitely don't have to be yours, but I hope that this gives you a sense of how I approach the issue, and you're welcome to take what you find useful from this framework and leave the rest. I will say that after doing this work for more than a decade, I do find this to be a helpful way to approach working with non-abstinent patients. It really helps me to approach people non-judgmentally. And for me, it mitigates some burnout of the work because it means that I'm ultimately not responsible for what other people do or don't do. I'm only responsible for how I treat them. So just starting at the top, I think it's important to acknowledge that drug use is nearly a universal human behavior that most cultures have engaged with in some form since the beginning of recorded human history. There is something uniquely human about using chemical substances to alter perception, whether that's caffeine, alcohol, ayahuasca, fentanyl, or really any other substance. And so while the act of substance use itself to me is morally neutral, it's not good or bad, it just is, that doesn't mean that there aren't real personal and societal harms associated with drug use. Of course, we all know that there are and that there often can be. Those harms are largely determined by the properties of the substance itself and the societal context in which that substance is used. Most people do use substances, and most substance use does not meet criteria for a DSM substance use disorder. However, that doesn't necessarily mean that there aren't risks and harms associated even with non-DSM substance use. And of course, we should try to mitigate and reduce those harms wherever possible. Um, However, it is not my job to stop people from using drugs because I am a doctor. I am not the police. Um, the police have been famously unsuccessful at this for many decades, and so I'm not going to try to take over the work that they do. It is my job to help people stay alive and stay as healthy as possible, though, regardless of their substance use. And that applies the same to my patients with substance use as it does with diabetes. And I'll make that comparison a bit throughout. But for my patients with diabetes, I continue to see them regardless of whether they're adhering to the treatment, whether they're making progress. We don't kick people out of care for that. Um, so I'd like to just sort of set the stage and discuss why engaging non-abstinent patients in treatment is more important now than ever. I'm sure everyone in this audience is aware that the current overdose crisis is not being driven by prescription opioids like it was 25 years ago during the first wave of the opioid crisis. And it isn't even being driven by heroin the same way it was 10 years ago during the second wave of the opioid crisis. It's really now being driven mostly by illicitly manufactured fentanyl, which has led to skyrocketing overdose rates, peaking in the United States at 110 overdose deaths in 2022. But I think it's even too simple to say that it's a fentanyl overdose epidemic itself. It's really a polysubstance overdose epidemic. We are now seeing not only illicitly manufactured fentanyl, but fentanyl analogs and other novel synthetic opioids like nitazines, psychostimulants, particularly methamphetamine, and psychoactive adulterants such as xylazine, which causes sedation. So it's really a misnomer anymore to say that it's just an opioid epidemic. Most people are using multiple substances, whether they know it or not, and that does matter because it has clinical implications for how we would intervene to treat patients who are not ready to stop using substances or who might be using more than one substance. So don't worry too much about this graphic. I'm going to focus most of the discussion today on the overlap between opioid and stimulant use because that's what I see most frequently in my clinical practice. And because we know from the last slide that that combination is increasingly found in fatal overdose cases. And when multiple substances are at play, I think it makes sense to focus first and foremost on the one with the greatest impact on mortality, which in this case is fentanyl and fentanyl analogs. That is not to say that stimulants don't kill people, but in the majority of cases, stimulant use alone contributes to negative health outcomes over the course of years, usually to decades, whereas obviously synthetic potent opioids can kill people much quicker than that. And I'm also focusing more on the treatment for opioid use disorder, frankly, because we have very effective treatments for opioid use disorder if we make them available to the people who need them. And really, in this climate, nobody needs that more than people who are simultaneously using opioids and stimulants. If you can address the opioid use, you can still contribute significantly to decreased mortality, not regardless of what is going on with their stimulant use, but it does reduce their risk significantly. So I will move through the next couple of slides rather quickly because I think most people here are very aware of the incredible mortality benefit provided by medication for opioid use disorder like buprenorphine and methadone. But just to quickly level set, I do like to show this graphic. It's from a 2021 JAMA review paper, which looked at many RCTs, many cohort studies, 750,000 people total with opioid use disorder were included. And it looked at the risk of all-cause mortality and drug-specific mortality among people who were and were not on methadone or buprenorphine. And not to bury the lead, both methadone and buprenorphine are wildly effective in reducing mortality in people with opioid use disorder. Buprenorphine specifically, which I'll focus a little bit more on because that's what I prescribe in my practice, led to a 66% reduction in all-cause mortality and about a 60% reduction in drug-specific mortality. And for the data nerds out there, you may be interested to know that the number needed to treat to prevent one fatal overdose over a 1-year treatment episode with buprenorphine is about 40. So theoretically, if I see 40 buprenorphine patients in a week, which I do and more, I could be preventing one person every week from dying of an overdose in the next year. And as a primary care doctor, that is very impressive to me. That's on a scale of efficacy that we almost never see anywhere else in primary care. I compare that with the number needed to treat with aspirin, for example, to prevent one heart attack over 5 years, which is about 350. So I'd have to prescribe 350 people aspirin to prevent one heart attack over 5 years, or I could prescribe buprenorphine to 40 people and prevent one of them from dying of an overdose in the next year. So buprenorphine as well as methadone are both wildly successful treatments for opioid use disorder for people who are and are not abstinent from other substances. And not only do methadone and buprenorphine directly save lives by preventing fatal overdose, they also retain people in treatment, which is what we'll focus the rest of the talk on. I will spend the next couple of slides trying to prove to you that retaining people in substance use disorder treatment, even if they're not abstinent from all drugs, may actually have a mortality benefit independent from its effect on substance use reduction and is therefore an important outcome in and of itself. So this is a Kaplan-Meier curve. It is basically the Kaplan-Meier curve to end all Kaplan-Meier curves. Here we're looking at treatment retention in a Swedish cohort of 40 individuals with opioid use disorder, randomized to receive buprenorphine or no medication. And you don't have to be a statistician to see the difference here in retention. At the end of a year, 75% of people in the buprenorphine arm were still retained in treatment, and 0% of people in the no medication arm were retained. And in fact, all of those people had dropped out of the study by 2 months. Admittedly, this is a small sample. It is a research sample, not necessarily a real life sample, but it does mean that 75% of the people in the buprenorphine arm were still going to clinic appointments after 1 year. They were still meeting with their clinicians and their counselors, who at that point they had developed a year of rapport with. They were still engaging in motivational interviewing or getting screened or treated for HIV and hepatitis C. These are all beneficial outcomes of treatment retention that actually have nothing to do with abstinence, but that the people who were not retained in treatment never had the opportunity to benefit from. So you have to keep people in treatment to reap the benefits of treatment, and abstinence is not the only benefit of treatment. So I can tell you I would be thrilled if I ever had 75% retention in my program. That's not the case. In my clinic, I see about 80% non-abstinent patients, many of whom are experiencing homelessness or at risk of homelessness, dealing with many different priorities and a lot of chaos in their lives. And so 75% retention to me is aspirational. But we pursue a high rate of retention wherever possible, because we know that even for patients who aren't ready for complete abstinence, the benefits of treatment retention are still worth pursuing. And so I've been alluding to these benefits of treatment retention for non-abstinent patients, things like meeting with clinicians, accessing other healthcare services like HIV, hepatitis C screening, psychiatric care. All of those are benefits of treatment retention, even for patients who are non-abstinent. But to get more specific, it appears that treatment retention may actually provide a mortality benefit itself. This is a study out of Boston Healthcare for the Homeless. They looked at 1,400 patients in their office-based addiction treatment program over the course of a year to measure retention, buprenorphine adherence, and opioid abstinence. Retention over time, which is the dark green bar here, you can see, of course, on day one, 100% of people are retained. By 12 months, only 11% of people were retained in treatment. So that's obviously quite a drop-off and has to do, as I just mentioned, with our similar patient population. They also looked at buprenorphine adherence, which is the light blue bar or the third bar in. And you can see that actually most of the people who stayed in treatment actually did continue to take their buprenorphine. And then finally, they looked at opioid abstinence, which is the lightest bar on the far right. And there you can see that of the people who stayed in treatment and remained on buprenorphine, less than about half of them were actually abstinent from opioids. So that's despite showing up to their visits, despite taking their medication, many people were still using opioids. And mortality in this cohort was high. 13% of the cohort died over 12 months, and over half of those deaths were due to overdose, which is not surprising. But what was surprising was that they also found that having had one OBOT visit or office-based addiction treatment visit in the last month was associated with a 64% lower risk of mortality during that month. Part of that is that probably that those people were taking buprenorphine, but not all of that difference can be accounted for by just the medication adherence itself or by opioid abstinence. And remember that of the people who were still showing up at month 12, less than half of them were actually opioid abstinent, and yet their mortality was significantly lower. And so that suggests to me that retaining non-abstinent patients in treatment is protective against mortality. It's probably more protective if they are retained and taking buprenorphine and abstinent from opioids. But even in the absence of opioid abstinence, mortality is reduced by 2/3 in people who are showing up to their treatment appointments. And so I believe that patients don't have to be perfect in an OBOT treatment program like this to be successful and to meet health-related goals, like, importantly, staying alive. And especially for high-risk patient populations like this population and like my population, that we probably need to re-envision the stated goals of OBOT treatment. And when someone is using multiple high-risk substances, and when they face a 13% chance of dying from those substances in the next year, the number one goal of treatment really has to be mortality reduction. And abstinence, if that is achieved, can be celebrated along the way. So to recap, I hope so far we've established a few principles. Number one, many people are dying from combined opioid and psychostimulant overdoses. Number two, opioids, particularly fentanyl, is the most immediately lethal of the two substances and should probably be addressed first and foremost and most aggressively. Number three, buprenorphine reduces opioid overdose and all-cause mortality. Number four, buprenorphine also retains people in treatment. And number five, retention in treatment reduces mortality independent from abstinence. So our focus, I think, should really be on how to retain the highest risk patients, even or especially when they're using multiple substances and having difficulty achieving abstinence. And that's what we'll focus the rest of the slide on, is how we do that. And remember, substance use exists on a spectrum. So should our treatment options. People may move fluidly between periods of abstinence, whether voluntary or forced, managed use, and harmful use. And we need to have treatment strategies available to them at every point along that spectrum. We shouldn't wait for people to achieve complete abstinence from substances before we help them. If we do, we're essentially telling people that we'll only help them after they no longer need our help. And as clinicians, we need to have the dual skill set to treat the underlying substance use disorder regardless of ongoing substance use. Once again, this is not any different from how we manage diabetes in people who haven't yet achieved perfect glycemic control with an A1C under 7. We don't kick them out of treatment. We continue to see them. We focus on education, building motivation to change, and providing support for action. And that brings us finally to the 2024 ASAM guidelines on treatment engagement and retention for non-abstinent patients. Don't worry, we're not going to go through all 40 pages of the document. I did that so that you don't have to, but I will highlight some key elements of clinical guidance that I think are still underemphasized despite the progress that we've made up until now in the field. We will go through each of these actually one by one, taking more time with some than others. But I want to quickly discuss the evidence behind these strategies, as well as some challenges that you might face trying to implement them in clinical practice, because I think that's why many people are here, to try to get some tips and tricks for how to retain non-abstinent patients in care. And as we discuss those strategies, I'll talk some and use some examples of practical ways that we've been able to implement those strategies at Stout Street Health Center, which is where I work. And just as a bit of background, Stout Street is a standalone federally qualified health center that provides medical and social services to people experiencing homelessness. We have established a walk-in office-based buprenorphine clinic every Monday through Friday, where any person can walk in, regardless of insurance status, documentation status, photo ID, or anything else. And they can meet with a provider to receive a buprenorphine prescription the same day. They can fill it downstairs at our internal pharmacy free of charge. And they can meet with peer counselors, behavioral health specialists, and access a whole variety of ancillary and supportive health services. About 80% of our patients, I think, would be considered non-abstinent, meaning they're still using street opioids or stimulants, mostly methamphetamine or both. And so we've put a lot of thought and effort into becoming as low barrier as possible, which starts right here at the front door of the clinic and with strategy 1. I know this seems very obvious that we want to create a welcoming, non-judgmental, and trauma-sensitive environment, but an interesting thought experiment that I would invite you to participate in with me here is to sort of take yourself on a tour of your clinical environment as a patient who is new to the clinic, has a substance use disorder, maybe had to get high to get the motivation to walk in here today and ask for help. And so maybe they're feeling a little bit disoriented, or maybe they're in withdrawal, and that was the final straw that motivated them to walk into the door for the first time. But either way, think to yourself as you walk in the front door, how does it look? How does it feel? Which staff members do you encounter first, and how do they treat you? Are there places to sit? Are there snacks? How long does the intake process take? And could somebody with a substance dependence get through that intake process before they go into withdrawal, or would they have to leave first? And so thinking about those strategies, we've actually sort of redesigned our waiting room, which is here on the left. We have actually sort of installed our peer specialists in the waiting room to mingle and meet with people, especially folks who are new to the clinic, and really hold their hand through the intake process, which might mean taking a break and going out for a cigarette and coming back. But that way we ensure that people have some support as they walk through it for the first time. Of course, we are still a clinical environment, and so there's more we could be doing to making it welcome. We're not a community-based drop-in the way that the photo on the right is. And so I aspire to a more comfortable environment like that, but we have done what we can so far to make the environment as comfortable as it can be while still being sort of a medicalized environment. Strategy two, we'll spend some time here. Strategy two is to not require abstinence as a condition of treatment initiation or retention, which again probably sounds pretty straightforward. The SAMHSA guidelines themselves acknowledge that discharging people from substance use disorder care for continuing to meet the criteria of substance use disorder doesn't make a lot of sense. To go back to the diabetes metaphor, that would basically be like saying, I won't treat your diabetes if you continue to have high blood sugar, right? We should be treating their diabetes harder if that's the case. And yet, I'm willing to bet that many substance use disorder programs still operate in this way. And in my patient population, and likely in some of your patient populations, that just wouldn't work. Being completely abstinent on the streets is just not realistic for most people. And yet, most people would still like to have access to treatment when they feel like they need it and they want it. They'd like to have access to a supportive healthcare system and have a lower risk of dying. And as we've already established, program retention decreases mortality. So it's important not to exclude the people who need the care the most from the care that they need when they need it. So if strategy number two is do not require abstinence as a condition of treatment initiation or retention, strategy 2.1, which is a corollary that I made up, is to rethink expectations around use of secondary substances. Um, I'll give you a very specific example from my practice that I see all the time. Many patients who I see in clinic are on buprenorphine for treatment of their opioid use disorder, and they're having some level of success with it. They're coming to clinic appointments, they're taking it more often than they're not. They haven't had any recent overdoses. Things are going okay from an opioid use disorder perspective, and it seems to be helping them. But they're still using meth, and many of my patients wouldn't consider their meth use to be much of a problem in their lives. I may or may not agree with that, but that's how they see their substance use, and they're not motivated to make any changes about their meth use. And so, in those cases, if opioid use is like the diabetes, then stimulant use is the hyperlipidemia. Those are two different conditions, which are often comorbid with each other, but have different etiologies and they're treated differently. And I wouldn't stop somebody's diabetes medication 6 months into treatment just because their cholesterol was still high. I wouldn't expect their cholesterol to magically resolve because I'm treating their diabetes. It's the same with substance use. I shouldn't expect somebody's stimulant use to magically disappear just because I'm treating their opioid use. If somebody is motivated to work on their stimulant use, then we're going to need to address that separately. But it's not necessarily an indication that the treatment for their opioid use disorder is not working or shouldn't be continued. Strategy number three is to optimize clinical interventions to promote patient engagement and retention. That is fairly vague to me, so I sort of broke that down into some more concrete considerations. Um, you will obviously need to sort of tailor this to your own clinical environment and your resources and what your patients need. I'm very lucky that at Stout Street, we have a lot of these principles baked into the way that we already do our MAT clinic program. Like we provide hygiene items, snacks, and coffee during our peer group. We have an on-site pharmacy where people don't need ID or insurance to fill their medications. We have a flexible care model where people can make appointments or walk in. We have weekly to monthly visits. We have opportunity for engagement at some satellite sites. And we have integrated primary care, behavioral health, and psychiatry to help keep people engaged and to keep people coming back, regardless um, of what they need. And our strategy is if we can get them to come back for anything, any of these things on this list, then we can maybe get them to come back for their substance use disorder care also. Strategy number four from SAMHSA is to only administratively discharge patients as a last resort. We want to avoid turning our treatment system into a revolving door through which patients are pushed by one treatment center after another due to administrative discharges. Systems to prevent administrative discharges might involve de-escalation training, interdisciplinary administrative discharge panels, escalation of clinical care, etc. And then on the other hand, I think we can conceptualize the revolving door as a door through which we usher and welcome people who are coming back to treatment after a break. So if people are discharged or if they self-discharge from care, but then they come back, we should be open and welcoming and excited to have them back in care. Um, One thing I worry about a lot is that the more rapport I build with a patient, the more worried they'll be about disappointing me if they have a lapse or a relapse to substance use. And I think that makes it really hard for them to come back. So when people do come back, one of my favorite things to say to them is just that I'm so happy to see you again. People have so much shame and fear about returning to treatment. We need to make it as welcoming as we possibly can, and we need to make it as easy as we can. And if that involves telemedicine or mobile street outreach, that's even better. But whatever way people find their way back into treatment should be celebrated. Strategy number 6 from SAMHSA is to build connections to people with substance use disorder who are not currently seeking treatment. You'll be familiar with this cascade of care from the HIV world. In 2022, only 85% of people with substance use disorder did not receive any treatment. And you can see here that we lose people in every step of the process, from diagnosing opioid use disorder, linking to care, initiating medication, retaining at 6 months, and entering recovery. Um, so consider in your program how you might be able to partner with community programs that are tailored to the health needs of people who use drugs who are not currently accessing treatment. Community events, drop-in centers, street outreach are all great ways to engage with people and at least plant the seed that treatment is available, that it's welcoming, that we want them to come to us for help when they need it. And that can help to break down the barriers between people who need the care and the people who get the care. At Stout Street, we actually have a street medicine outreach buprenorphine program where we can dispense buprenorphine on the streets for a 3-day supply and then arrange for follow-up at our clinic within 3 days. And that has been pretty successful to engage people on the streets and actually build that bridge so that they can come into the clinic and receive our more comprehensive panel of offerings there. Strategy 7 and 8 I combined because they are, I think, similar and similarly important. None of this can be effective without staff buy-in, and I realize that that might vary considerably depending on where you are in the country, what type of work you do, who is on your staff. One thing that's been really humbling to me in doing this work is realizing just how important the people sitting at the front desk are. Especially, I think, in this work, people really develop close relationships with the people at the front desk who check them in. And if that doesn't go well, then I never even have the opportunity to try to offer help or build rapport with them because they walk right out and I never get to meet them. So the people sitting at the front desk are really, really key, and they should be educated and they should be supported, and we should really prioritize retention of the frontline staff. We think a lot about retention of clinicians and how disruptive it can be for people when their clinicians leave, but I think it also goes for the frontline staff because actually our patients have a lot more interactions with our frontline staff than they ever do with our clinicians who are behind that locked door. And so I recognize that staff often have, everybody has their own preconceived notions of substance use and what is acceptable, what is not, what is recovery or sobriety, and what is not. And people have their own traumas around substance use. At this point in our country, about 100% of us probably have had personal interactions, personal experiences with substance use, either ourselves or close friends or family members, and that may have colored how we think about recovery and treatment. But those experiences can be leveraged to build close relationships with patients as long as the staff feel like they have the support that they need to process their feelings and to try to approach patients in a welcoming and engaging way. And so ongoing education and support of that frontline staff is really, really crucial, not only for improved patient outcomes, but for staff satisfaction and retention and prevention of burnout. Strategy number 9 from SAMHSA is to align program policies and procedures with the commitment to improving engagement and retention of all patients, including non-abstinent patients. I find these strategies to be very vague and hard to parse and understand. So I had to sort of write out some examples of I think what they're talking about. What they're talking about is not having unnecessary administrative burdens or barriers to people accessing care. So, offering flexible booking appointments or walk in hours goes a long way to help people make use of the care that you're trying to offer. Minimizing administrative burden during intake, again, thinking about the burden of paperwork and how many staff members each new person has to meet with before they meet with their clinician, and how long does that take, and can they read and write well, and are they in withdrawal and in a headspace to do 45 minutes of paperwork. Just really trying to walk yourself through the process and think about how it can be made as streamlined and easy as possible. That's a huge barrier for people that keeps them from coming in the door in the first place. We try really hard to avoid administratively limiting patients' access to medications, which means trying not to hold patients' medications hostage by saying that you can only get your second refill if you get your labs done first, or you can only increase your dose after you've had your EKG. In some situations, that might be clinically important, and if so, that's a different situation. But a lot of times, that's just sort of administrative policy that actually limits people's access to medications without offering a lot of clinical benefit. So a major pet peeve of mine is mandatory EKGs for all methadone patients, because most of our methadone patients are not on 6 QTC prolonging medications and don't have a history of structural heart disease and don't have a personal or family history of torsades. And they probably don't need a pre-treatment EKG or an EKG with every dose escalation. That's just going to restrict their access to care. And so if a patient does have any of those things, by all means, please get the EKG, use your clinical judgment. But we try to think really critically about what we're requiring and why. And any prerequisites to starting somebody on treatment should ideally be medically necessary for the safety and the well-being of that person, rather than just being part of sort of like an administrative package where we have to check off the boxes as people register for care. And then strategy 10 is encouraging programs to measure progress and strive for continuous improvement of engagement and retention. So you improve what you measure, right? And the outcomes that you care about might be different than the outcomes that I care about. What we really care about at our clinic is retention because of all of the reasons we've just talked about and the incredible mortality benefit provided by buprenorphine, even for people who are still using other substances. And so we focus really hard on retention. Things that we have done to try to improve retention, we've made heavy use of our peer support specialists who, as I mentioned, try to meet with every new person and walk them through the intake process, try to call every new person after their first visit and before their second visit, because we identified that that's where we lose about 60% of our clients is people who come in for the first visit and then they never come back for the second visit. So if we can close that gap, that would go a long way towards increasing our retention. Again, we try to provide basic needs items. We try to keep people just coming in the door in whatever way we can, with the hope that if they walk in the door for coffee or a backpack or to meet with a peer, they might also be willing to stick around and meet with their clinician and get their next prescription of buprenorphine and fill it and reduce their mortality by 60%. So you have to decide with your coworkers and your environment, what are the outcomes that you want to study? Maybe your enrollment numbers aren't what you had hoped and you really want to increase recruitment and enrollment. Or maybe you're noticing people are really having a hard time filling their prescriptions at pharmacies and you really need to figure out how to better support people in going from getting the prescription to filling the prescription. But whatever those outcomes are of interest, I really encourage you to start by studying it, just recording it and figuring out where you're at, what's the percentage, where do you want to be, and then how can you build the stepping stones between where you're at and where you want to be. We are very lucky at Stout Street. We have a grants team that helps us gather and sort of parse through some of this data. And so we looked at our retention status recently. This is 6-month retention, the red, yellow, and the green bar. And we found that we have about 40% retention at 6 months, which is huge. It's not the 70% from the buprenorphine study, but it is better than we thought it would be. And it is better than the national average for OBOT treatment programs for people experiencing homelessness, which is probably closer to 20 or 25%. So we think we're doing something right in terms of retaining our patients who are mostly non-abstinent. And then on the right, we actually do quarterly, sometimes biannually focus groups with our patients to ask, what do you like about our program? What could be better? What's working, what's not working? And we collect some good qualitative feedback and some good ideas for improvement that way. So whatever your programmatic goals are, I encourage you to get together with your staff, with your coworkers, and think about how you might measure that at baseline, how you might look for improvement, and where you would like to be in 6 months or a year, and try to make those things happen. And I think that is just about all I have for you guys. I hope I left time for questions. It looks like I did. So I will wrap it up there. I'm happy to take questions to the best of my ability.
Thank you so much, Dr. Axelrath. At this time, we do not have any questions in the chat. However, in the chat, there is a lot of rave about the strategies. People really, really enjoyed the talk. However, we do still have time for questions. So if you have questions, please add them to the chat, and or you can raise your hand.
Not sure if Ashley dropped out or that was Ashley. I think we lost you for a minute.
So sorry about that. That happens here and there, and I had gotten through to the questions without it happening. So I thought I was in the clear. Um, so if I do see a question in the chat. How to encourage PCPs to subscribe Suboxone?
Yeah, excellent question. Um, Well, as you probably know, the X waiver has been eliminated, so that removed one barrier. As you might also know, that didn't actually increase rates of PCP prescribing of buprenorphine by all that much, which seems to imply that the PCPs who were interested in prescribing buprenorphine were already doing it and had jumped through the hoop of the X waiver in order to do it, and the people who weren't interested in doing it weren't going to do it anyway. That's unfortunate. I think my strategy when I talked to other clinics about this is to emphasize that it's a primary care issue. There is no reason it needs to be managed by a specialist. It is not more complicated than starting and titrating insulin, which we do all the time. It is actually much less complicated than that. And like anything else, it just requires some continuing education, ideally some mentorship from a champion at the clinic. If there's one person at the clinic who's really interested and really enthusiastic about taking on some of that administrative burden to train up your colleagues, make yourself available as much as possible for like consultant questions if somebody runs into a situation that they're not familiar with in real time. I think having a clinic champion is really, really important. And over time, you can kind of cultivate your coworkers and help them understand that this is not a difficult task. And it really is part of their job as primary care doctors to treat substance use disorder, given that something between a fourth and a third of patients in primary care offices are dealing with substance use disorders or health consequences of substance use disorders.
Okay, thank you. Okay, we got questions rolling in. I've got a few in the chat. I'm gonna try to catch them from the chat so I don't lose them. The first one I see is, how does your clinic use contingency management?
Great question. Contingency management is receiving a lot of attention and buzz right now. I guess that was conspicuously absent from my slides a little bit because we are sort of just now getting some contingency management programs up and running. We have recently gotten funding to start a very small pilot contingency management group for people using stimulants in one of our housing programs, but unfortunately, it's not going to be open to all of our patients just yet. So we have not been using financial contingency management yet. We hope to start that within probably the next 3 months. Um, I think we use some contingency management, probably like most places do. We do have sort of some baked in rewards for increasing clinic attendance and adherence. Like most people, start with a week's prescription and then they extend to 2 week prescription and then a month prescription, depending on how they're doing and how stable and how compliant they've been with their medication and their treatment plan. So even that is kind of built in contingency management. Um, but I certainly encourage people to look into financial contingency management depending on your setting and your resources. It is definitely the most effective treatment that we have for stimulant use disorder at this time.
Okay, thank you. There is a question about the slides. Yes, the slides will be made available on NAHUD's website as a resource. Okay, here's another question. How are you able to offer this without insurance involvement? Do you have any funding ideas?
We are lucky. We receive, I believe the last time I was educated about this, I think I was told that we receive about 60% federal funding. The rest is a mixture of state grants, city grants, and like private philanthropy, and also billing Medicaid. So I will say we do bill Medicaid for our patients who have Medicaid. So that's a huge part of our revenue source. But we have other funding streams available to subsidize the cost of care for people who don't have Medicaid. So that is kind of the extent of what I know about it. But I know that we are very lucky to be able to have that, and not everybody does.
Okay. Here's another one. How do you handle patient irritability and agitation in the clinic setting when it occurs?
Um, Frequently, we handle that frequently. We have a security team. We call them our safety team. They are ununiformed. They are unarmed. They are not. Some of them are not necessarily like law enforcement trained in any way. They would be hard to pick out in our clinic as our security team, and they are incredible de-escalators. They're incredibly, incredibly skilled de-escalators. Um, they are very good at identifying sort of what the underlying need is, right? When somebody is irritable or escalated or angry, there's usually an underlying need behind that. It could be that they haven't slept in 4 days. It could be that they're really hungry and they need a snack, or they just need a quiet place to sit down for a while. And so our security team are just the most skilled de-escalators, and I think that goes a long way. And they don't seem to worsen the escalation the way that sometimes calling in people in uniforms can. And so they're a huge benefit to us. I think they keep us safe. They keep our patients safe. They keep, um, they keep, law enforcement out of our clinic when possible, when it's not really necessary and would probably just escalate the situation further. I saw a question earlier about LAI buprenorphine. We definitely do use both branded versions of the LAI buprenorphine. We've had excellent success with both. I think there is a misconception that you have to be fairly stable on buprenorphine for some period of time in order to somehow like qualify or be appropriate for the long-acting injectable buprenorphine. But the truth is that if somebody can tolerate sublingual buprenorphine without precipitated withdrawal, and if they want to be on the long-acting version, and if they're clinically appropriate for it, do it. And we've had great success, particularly in people who are unstably housed, really motivated to be on buprenorphine, but are facing a lot of legitimate logistical challenges with losing medication, getting medication stolen, temptation of just being exposed to illicit drug use all the time in our part of town. So for anybody who wants to be on LAI buprenorphine and is clinically appropriate to, I really, really recommend it if that's available to you.
Okay, do you have any suggestions for communicating with parents, spouses, etc., who want patient to be abstinent?
That's actually one of my favorite things to do. That's a really powerful opportunity to sort of engage the family in care, which I don't often get to do as an adult doctor. A lot of my patients are estranged from family and they don't have that level of support. But if somebody has family that's willing to like join them in that conversation, then that you can take a strengths based approach to that. Like that's somebody who cares about that person, who wants to be involved and just, I think, needs some education and some cultivation. And so I think that's a really good opportunity to, if your patient is willing, with their consent, of course, to invite that family member in to have a conversation, to hear the family member's concerns, which is probably that they carry their own trauma and that they're really worried about this person and they don't understand why or how this medication is supposed to be helpful. But I have found that most of the time people are movable on that spectrum. If you just approach them from a place of it's clear how much you care about this person in your life, let's work together to, to make this medication and this treatment plan work for somebody.
Okay, so the next question is there's a lot here, so I'll try to break it up a bit. This person works for a walk-in low barrier MOUD medical clinic in Philly, and they're learning how learning how you all do things is very inspiring. They have a few questions, but they're going to try to keep it brief. First question, do you have a cap of how many patients you see each day?
Uh, no, we are a walk-in program. So we try really hard to see everybody who walks in that time period. We actually do have we are busy enough that we have two providers seeing patients simultaneously for the walk-in clinic, just alternating back and forth, taking one, taking the other as they come in. And so there have been some really busy days where we have had to triage a little bit and say, for this patient who's really, really stable, maybe I can just send their prescription to the pharmacy and catch up with them next month. Maybe I don't need to have a full visit with them, but we try really hard to see every person who walks in, and we're lucky to have the staffing support to be able to do that. But we are busy.
Okay, the next question is how does your clinic handle frequent self-discharge and returns?
Um, we see that all the time. I guess it depends a little bit on what you mean by self-discharge. We don't have like a formal discharge program or process. People just, stop showing up for a while and then they show back up again. And when they show back up again, we're excited to see them and happy to welcome them back into our program, as long as they seem to want to be there and to give it another shot. I think that not having a formal discharge program like process is actually very helpful for us if that's something that your program could consider, because I think once someone goes through a formal discharge process, they feel like they're done and that it's over and that they can't come back. But people kind of do wander out and back in of to our treatment program all the time, and because it's kind of informal and it's walk-in, we get caught up with them. Where you been? How things been going? What's the situation? And then we just kind of pick up where we left off.
Okay, they said that they're finding this to be one of their challenges. For example, folks will try to come a couple days too early to get their medication, and when they explain to them that they can't get their medication early, they ask to discharge and go elsewhere. But then they return a couple of days or a week later because clinics are limited. And they thank you for your expertise.
I will also
Uh,
I will say that we are able to avoid a little bit of that because we have an internal pharmacy that's very flexible. And
mm.
so while we do bill Medicaid, and it's true Medicaid won't pay for their prescription before it's due for its fill, we have an internal pharmacy that is willing to sometimes give people that like 2 or 3 day bridge, which is of buprenorphine, which is non-reimbursable. But we have, as I mentioned, we have other funding streams to help cover that. So again, I recognize we're really, really lucky and well resourced. And we have a pharmacy who's willing to sometimes be that buffer so that we don't lose people during those frequent kind of like lapses and like overlapses in care.
Okay, and for the last question that we have in the Q&A pod, is there any way to partner with the drug distributors to reduce overdose?
Interesting question. I'm sure I am probably not the best person to answer that question. That I think is a conversation, that's an interesting conversation that I think does happen maybe more in like sort of community like community drop-in and organization spaces. I think I wouldn't know where to begin, sort of as a medical clinician. But if other people have ideas of how to, partner um, with the drug distribution pipeline, I think that's an interesting idea. I think it's also important to recognize that like most at the level where I work, most people who use drugs also sell drugs or also trade drugs. And so the lines between like drug user and drug seller are very blurred. And a lot of times it's just like low level subsistence level selling back and forth. And those people you can definitely intervene with. I can educate those people on maybe testing their meth for fentanyl, having test strips, educating the people that they're going to be selling or giving that substance to about what's in it. So I think at that level, it's very possible, but I wouldn't know where to start necessarily at like the higher levels of distribution. I stay out of that.
Okay, I think that is the last question we had. If you could take a few moments, the evaluation link has been dropped in the chat. If you could take a few moments to complete the evaluation, or you could wait for the evaluation link to be sent to you via Zoom. Um, Dr. Axelrath, we thank you so much for your presentation today. And if there are no other questions, we invite you to register for our next presentation that will be HIV and substance use disorders, implications for elder populations. That will be hosted on October 3rd from 12 to 1 Eastern Time. Thank you all for your time today, and hope you enjoy the rest of your day and have a wonderful weekend. Dr. Axelrath, we will talk offline.
Thank you so much for your time, everybody. Pleasure to be here.